Okay. So, case number U1, Ms. Celine Jasmine Mason. You can upload your presentation.
Yes, ma'am. Good morning, ma'am.
Good morning.
Just a question, ma'am. Who's going to look like they'll talk about the time you will be doing that one?
I'll also keep it. Yeah, I'll be keeping a timer here.
Oh.
Okay, at the end of 5 minutes, I'll announce.
Sure.
Is that okay, Dr. Gopi?
Please, thank you. Yeah.
Okay. Your presentation is not okay. Your presentation is visible. You can go to slideshow mode. Your time starts now.
Good morning, all. I am Celine Jasmine Mason, doing my BAptem second year in Dr. Agarwal's Institute of Optometry, Tirunelveli. My case report is about anterioritis. Anterioritis is defined as the inflammation of the uveal tissue that includes iris and extends to the pars pliccata ciliary body. Anterioritis can be categorized into three types: iritis, iridocyclitis, and cyclitis. Symptoms include pain, redness, photophobia, lacrimation, impaired vision, and blepharospasm. Signs will be associated with the condition that include eyelid swelling, congestion, corneal edema, posterior corneal opacity, aqueous cells and the flares, hypopene, and iris nodules. Mostly, anterioritis is treated with the topical corticosteroid and in some cases cycloplegics to prevent pain and to reduce complication. My case report demonstrates about a 24 years male presented with the chief complaint of redness and pain in right eye for past 2 days. No ocular history, systemic history, medication history, allergic history, and family history. The patient's distance uncorrected visual acuity was 6/6 in both eye and near uncorrected visual acuity was 6/6 in both eye. Slit lamp examination reveals normal in the left eye, but right eye shows congestion and discharge in conjunctiva, endothelial dusty in cornea, cells and flares in the anterior chamber, fine dispersion and back of the cornea. This clinical findings helps to diagnose the anterioritis in right eye. Treatment include dextronius 4 times a day by tapering, Lobrex 4 times a day for 3 weeks, moxicram 4 times a day for 1 week, pomade 2 times a day for 1 week. Anterioritis was resolved after 5 days of follow-up. Coming to the discussion part, Hardan et al. Found that idiopathic cases of anterioritis is 48 to 70%. It mostly occurs in the young males with the symptoms of redness and photophobia and presence of the anterior chamber cells and flares. Anterioritis can be caused with the systemic illness, trauma, infection conditions like HLA-B27. Anterioritis can be treated with the corticosteroid and the anti-inflammatory drug. Also, it's crucial to monitor with the regular follow-ups. I conclude this case with the importance of early diagnosis and treatment. Continuous follow-up is crucial to prevent complication and providing potential need for the recurrence. These are my references. Thank you, ma'am. Thank you, OATN, for giving this opportunity to present my case.
Thank you, Ms. Celine.
Thank you, ma'am.
Completing well within the time limit. Over to the judges for your question answers.
Okay, ma'am.
Raksha, ma'am, you can start.
Okay, fine, thank you. It was a very good presentation, very neatly presented. So
Thank you, ma'am.
I have a very basic question. It's a 24-year-old boy. So what you think could be the reason for anterior uveitis in this kind of situation? any reason, or you could think of any, you just mentioned HLA-B27, right?
Yes, ma'am.
So do you think that would be the reason for his uveitis?
Yes, ma'am.
Okay, fine. Why was moxicram prescribed? What is the need to prescribe moxicram?
To reduce the bacterial infection, ma'am.
To reduce, was there a bacterial infection?
No, ma'am.
Then why was moxicram given? Could you tell me why antibiotic is given in such cases?
These are
No? Pardon me?
Yes, ma'am.
Was there a bacterial infection? Hello, can you hear me?
Yes, ma'am.
Yeah, so, okay, fine. I'll move on to one last question. Can you tell me, see, there are a series of tests which are indicated in uveitis. Okay, so can you just name any two tests which we can do for confirming what could be the reason for uveitis, other than HLA-B27? No?
OCT, ma'am.
No, I'm asking about systemic, for
Investigation.
systemic, any kind of systemic disease.
CT scan, ma'am.
CT scan.
Or blood tests.
Blood tests only. There are many types of blood tests. Which one particularly? Okay, fine, no problem. Gopi, you can go ahead.
Thank you, ma'am. Good presentation, Selim. I just have a couple of questions. Again, a very basic question. Couple of things as already asked by Daksha, ma'am. Why we have to taper this kind of drugs in these cases? Do you have an idea? What is the reason we ask the patient to taper? Did you get my question?
Yes, sir.
So what do you mean by tapering?
Corticosteroid should be tapered, sir.
So
To reduce it by week,
what do you mean by tapering?
to reduce the medication dosage, sir.
Okay, why we have to reduce the medication dosage in these cases?
Mm.
And last another
It can lead to complications, sir.
why which can lead to complication.
Mm.
What happens if you use it for a year continuously? Especially the Dextron.
It can occur again, sir. It can lead to recurrence case.
Okay, so as an optometrist, what do you think is the role over here in this specific case? Your role as an optometrist.
With proper instructions to reduce the antibiotics, sir.
Okay.
And to follow the case, sir.
Okay. Fine. Thank you, sir.
Thank you, sir.
Over to you, Preethamandi.
Yeah, thank you, Dr. Gopi and Daksha. I request the judges also to restrict their time limit to 2 minutes for the question and answer session. So over to the next presenter, U2, case number U2, Sudalai Vadivu. All the very best for your presentation. You can upload your presentation. Is Sudalai Vadivu there? If not, we'll move on to the next person.
Yes, ma'am, I'm there.
Oh, you're there? Okay.
Yes, sir.
We can see your slide. You can start.
Okay, ma'am. Good morning, all. I am Sudalai Vadivu, doing B Optum third year in Dr. Agarwal Institute of Optometry, Tirunelveli. My case report is about idiopathic intracranial hypertension. Idiopathic intracranial hypertension is defined as increased cerebrospinal fluid pressure with an unknown etiology. This case, initially known as pseudotumor cerebri, but now recognized for its unknown visual loss, idiopathic intracranial hypertension often occurs recurrent due to reduced cerebrospinal fluid outflow and by normal ventricular size. It indicates no hydrocephalus and central edema. Idiopathic intracranial hypertension common symptoms are severe headache, pulsatory tinnitus, and transient visual disturbances. Most probably, the diagnosis relies on papilledema and cranial nerve palsy, especially it involves sixth cranial nerve. Vitamin A supplements and lifestyle modifications like reduced sodium level in diet and weight reduction, which manage the symptoms. The success rate of other treatments have a significant risk of visual loss. Regular follow-up and treatment are essential to reduce intracranial pressure and symptoms. This case represents 45-year-old female. The purpose of visit is routine eye checkup. The general observation I observed was vitiligo in both hands. The patient using spectacle for past 7 years with PG prescription in the right eye was minus 2.25 diopter sphere with minus 0.5 cylinder at 75 axis. Patient read 6 by 6 in Snellen chart. In left eye, minus 3 diopter sphere, minus 0.5 cylinder at 130 axis, patient read 6 by 6. Add prescription. Add prescription plus 1.5 diopter sphere, patient read N6 at 33 centimeter. The subjective refraction found same as previous class prescription. Slit examination revealed both eye fundus shows post-edema and secondary optic atrophy and the cup disc ratio of 0.6 disc diameter in right eye and 0.5 disc diameter in left eye, whether other structures are normal. We further investigated fundus photo, OCT, and HFI evaluation. The fundus examination revealed 0.6 cup disc ratio in right eye and 0.5 cup disc ratio in left eye. The OCT RNFL scan shows reduced RNFL thickness in right eye and nasal quadrant in left eye with optic atrophy. The macula cube showed post-edema in the macular region. But the HFI shows normal visual field in both eyes. Based on this finding, it was diagnosed with idiopathic intracranial hypertension. This patient treated with Reno Plus tablet for 2 months and advised for same plus prescription with regular follow-up. Coming to the discussion, this case discussed about the need for ophthalmic assessment in patients with visual impairment. The examination finding clearly suggested post-edema optic atrophy that can lead to visual disturbances. The co-occurrence of vitiligo that is not directly to the ocular finding. Fundus photo, perimetry, and OCT were diagnostic tool. It reveals signs of idiopathic intracranial hypertension. This can be managed with a supportive treatment to prevent further visual impairment. I am concluding this case with the importance of prompt diagnosis and intervention strategy in case of visual impairment related to condition like idiopathic intracranial hypertension. Effective treatment and regular follow-up are really essential to prevent the condition and to manage the idiopathic intracranial hypertension. These are my references. Thank you, sir.
Very well presented, Sudalai.
Thank you, ma'am.
Over to the judges, please.
Poppy, you want to do it first? Poppy, shall I go ahead?
Can I ask? Okay. Fine.
Yeah. Please ask.
Fine. So really very good, nice presentation. I just have one. Did the patient also reported any headache by any chance?
No, sir.
There was no sign of headache.
No, sir.
Okay, fine. Because I was looking through your case, and when I looked at the literature, vitiligo and some form of headache along with the intracranial hypertension has been reported, but it is rare again. So I think you should look at the literature and also ask the patient when the patient comes back whether they are facing any headache. It can
Okay,
be
sir.
occasional or like frequent. That's all from me. Thank you.
Okay, sir. Thank you, sir.
Hi, it was a very good presentation. Something which you could pick up with the vitiligo that was very nice. So my question is, what are the other symptoms a patient with idiopathic intracranial hypertension can come? One which Dr. Gopi just mentioned, headache. Could you tell me what other symptoms would help you diagnose this?
Nausea, vomiting, neck pain, tinnitus, ma'am.
Nausea, vomiting, neck pain.
Neck pain, tinnitus.
Okay. Anything related to the eye?
Temporary blindness இருக்கும் ma'am.
Okay, fine. Thank you.
Thank you, Daksha.
Ma'am,
So we are on time. We'll move on to the next presenter. Case number
you, ma'am.
yeah. Best wishes to the line. We'll move on to the next presenter. Case number U3, Miss Madhunisha.
Good morning, ma'am.
Good morning, Madhu.
Is my screen visible, ma'am?
Yes, you can go to slideshow mode. And your voice is clear. You're good to go.
Good morning to one and all present here. I am R. Madhunisha, studying in
Sorry to interrupt.
Oh, yes, ma'am.
Yeah. Can you go to slideshow mode?
Ma'am, it is in slideshow mode, ma'am.
Is it?
Yes, ma'am.
How does now it is in slideshow mode?
Shall I start, ma'am?
You can.
Good morning to one and all present here. I am R. Madhunisha, studying BSc Optometry third year in Lotus Institute of Health Sciences and Management, Coimbatore. I am here to present a case on post-typhoid retinitis, a rare sequelae of systemic infection. Typhoid fever is a systemic bacterial infection caused by Salmonella typhi, primarily transmitted through contaminated food and water. While the disease commonly affects the gastrointestinal systems, a rare post-infectious immune-mediated complication, including post-typhoid retinitis. This condition is characterized by retinal inflammation, macular edema, and vitritis, leading to progressive vision loss. Early recognition and appropriate treatment are essential to prevent irreversible visual impairment. Here is a case history of a 29 years old male came to the hospital with the complaints of bilateral gradual vision loss for the past 10 days. There is no associated complaints such as pain, photophobia, or floaters. There is no past ocular history of trauma, surgery, or laser, and no history of using glasses. But the patient has past medical history of fever 20 days before his visit, and it was diagnosed as typhoid fever. And he was treated with antibiotics for 5 days. And no history of recurrent fever, cough, joint pains, or oral or genital ulcers. No relevant family and allergy history was recorded. His clinical findings showed visual acuity of 6/18, N10, and no improvement with pinhole in right eye, whereas left eye showed CF at 3 meter, less than N36, and no improvement with pinhole. Refraction showed clear reflex, and acceptance remains the same. Keratometry, intraocular pressure, axial length remains within the normal range. Slit lamp findings showed few keratic precipitates in the right eye, grade 2 anterior chamber cells, vitreous cells in both right and left eye. Fundus examination showed macular edema, retinitis along with superior and inferior orchids in right eye, succinate exudates, retinitis along with superior and inferior orchids in the left eye. From the above findings, it has been diagnosed as post-typhoid retinitis. I have attached a fundus image for your references. We can see that first visit showed lesser exudates than the second visit. Initially, patient is asked to use Predford eye drops for 5 days. When the patient came after 2 weeks for a second review, we can see that vision has been improved to 6 by 7.5 in right eye, 6 by 18 parts in left eye. Infection screening such as venereal disease research laboratory test, rabbit plasma regain test, human immunodeficiency virus test, Mantox test, quantiferon test are all negative. Patient is asked to start anti-tuberculosis treatment along with oral prednisolone. On the third review, we can see increased exudations on both eye and decreased subretinal fluid and intraretinal fluid on OCT in both eye. Patient is asked to continue anti-tuberculosis treatment to avoid steroid-induced tuberculosis flare-up. We have been discussed that post-typhoid retinitis is a rare but serious ocular complication following salmonella infection. Corticosteroids play a crucial role in managing post-retinitis by controlling immune-mediated inflammation and preventing further retinal damages. Improvement in vision and OCT findings indicates a positive response to the treatment. In this case, the absence of systemic symptoms and negative infection workups supported the diagnosis of post-typhoid retinitis. I concluded that post-typhoid retinitis is a rare immune-mediated ocular complication that can lead to significant vision impairment if not promptly recognized and managed. Treatment with corticosteroids helps to control inflammation, but in endemic region, anti-tubercular therapy may be initiated as the precaution. Regular follow-up with OCT and fundus evaluation is necessary to monitor treatment responses and prevent long-term complications. Maintaining proper hygiene, safe drinking water, and sanitation is crucial to prevent infections and its complications. These are my references. Thank you for this wonderful opportunity. Thank you, ma'am.
Yeah, thank you, Ms. Madhunisha. That was a very insightful presentation you presented to. So over to judges. Daksha first. Would you like to go first?
Yes. Madhunisha, very good presentation.
Thank you, ma'am.
Very well presented. So you saw that the concerned doctor had given him anti-tuberculosis treatment as well, right?
Yes, ma'am.
So could you tell me why is it a concern? Why is TB a concern in cases of typhoid?
Because ocular tuberculosis can exist in latent form, ma'am, which may get reactivated with steroid therapy. So that the doctor advised anti-tubercular therapies, ma'am.
Thank you.
Thank you.
Right. A nice presentation.
Thank you, sir.
During the third follow-up, was there anterior chamber reactions or whether it was resolved? Can you explain on that? Like, why did you see flares and KPs in the first visit? Is there any relationship between the overall disease and the use of drugs or the other secondary complications? Can you explain on that?
Sir, could you please repeat it again, sir?
You go to the previous slide, no? The previous one. Yeah.
Yes, sir.
There are KPs, anterior chamber cells, and vitreous cells, right?
Yes, sir.
During the third visit, how it was, and what is the reason of having all these slit lamp findings in this specific case?
Sir, could you hear me?
Yeah, can you?
So the presence of anterior chamber cells and keratic precipitates in the first visit suggests an inflammatory response in the eye, sir, due to post-typhoid retinitis.
Okay.
And it also includes that uveitis anterior segment involvement because of anterior chamber cells, and it was in grade 2.
Okay, thank you.
Thank you, sir.
Very confident responses, Madhu.
Thank you, ma'am.
Do the best.
Thank
So,
you, ma'am.
go on to the next presenter. Case U5, Ms. Harita Devan. We have a good number of college students attending today in support of all the undergraduates presenting today. Very good to see this. Thanks to all the faculty for joining in too. Harita, are you there? U5, Ms. Harita, are you there? Okay, we are not able to hear you. We'll move on to the next presenter, Ms. Niveda, U13. Yeah, you can
Can you able
upload.
to hear me now?
Who is this?
From SRM. Niveda Purushothaman from
Niveda.
SRM.
Yeah, U13, you can upload Niveda. Go to screen show, slideshow mode. The time
Shall I
starts.
start? Okay. So
Yes.
good morning to everyone present here. So this is Niveda Purushothaman from SRM Medical College, Katangattu. So first of all, happy World Optometry Day to everyone. And let me start my case. My case is on a guidelines for proper steroid tapering after phacoemulsification. So most common complication which occurs after cataract surgery is rebound iritis. So rebound means that returns iritis, which shows an inflammation of anterior uveal tract, where if the steroids are not continued properly or it is stopped too quickly, the rebound that may lead to one of a complication of rebound iritis. The patient experiences symptoms such as pain, redness, light sensitivity, and blurred vision. Sign includes flash and pupil. In severe cases, there will be an hypopyon with KP, and there will be if it leads to more severe, it may happen posterior. It may lead to posterior synechiae. And the complication which includes steroid-induced cataract, glaucoma, and cystoid macular edema. So in our case, 64 years female who came with a complaint of sudden onset of severe redness associated with moderate pain and intermittent watering with photophobia. Right eye, no such complaints, and no difficulties in distance and near vision, and no history of headache. This previous ocular history says she was undergone phacoemulsification in right eye. It was done in February. In left eye, it was in December. And he also has a history of diabetes mellitus. He was taking a medication of metformin tablets since 2 years, and his FBS and PBS remains normal. The past medical history says that he was using prednisolone and moxie and homoatropine for cataract. And he also says the issue of he was using prednisolone without tapering. He was continuously using without using the drugs without gradual tapering schedule, and he was suddenly stopped after 1 month. His vision was in right eye, it was 6/6, and left eye, it was 6/9, and near was N12 in both eyes. In pupil, it was showed in right eye perla, left eye, it was perla with the sluggish pupil, myotic pupil. It takes time for dilation. And IOP in NCT, it was 16 in right eye and 16.5 in left eye. And slit lamp, it was right eye within normal limit, and left eye there is circumcorneal congestion with +2 aqueous cells and flash. And fundus, it was normal. You can see in this picture, the pictorial documentation shows the upper lid and lashes was normal. You can able to see there is a circumcorneal congestion with the sluggish pupil. This is a reference image. It's not the patient image. So it was diagnosed as rebound iritis, and the management was reintroducing of prednisolone. It was slowly, gradually tapered based on the schedule. And homoatropine was also given for relaxing accommodation to prevent pain. And after follow-up, the inflammation was slowly reduced within a week, and it completely resolved within 4 weeks. So let us discuss the case. First of all, the patient is 64 years old with the complaint of redness and pain with photophobia. So she's post-cataract surgery. So he also reported that there is abrupt discontinuation of steroids. So when there is so after cataract surgery, what happens? First of all, the inflammation happens, right? So when the inflammation happens, so to prevent the inflammation, to stop the inflammation, our body naturally produces leukocytes. So what happens? These leukocytes will act as a defensive mechanism. So when there is an overacting or overaction of leukocytes, there will be the tissues. The immune cells will damages the tissues. So the steroid drops will suppresses both inflammation and leukocytes. Once the inflammation is get to be controlled, the leukocytes will stop entering. What happens if the steroids are stopped abruptly? The artificial steroids are continuously used. When it stops suddenly, our body produces cortisol. The artificial steroid will compresses the natural steroid. That process is known as steroid compress.
1 minute left.
Okay, ma'am. So there will be a lack of cortisol, the natural steroid. Then the leukocytes will come again, and it bounce back and it produces rebound iritis. This is one of the complications after cataract surgery. So the patient is educated and reintroducing of steroids, and the patient is completely recovered in our case. So according to me, as an optometrist, you want to educate the patient that such a way that the steroid schedule that they are the tapering schedule should be given properly and monitored essentially. So a prevalence is that 1.2% of incidence has remains and conquer, but over 1 million the cataract surgeries. So if you see 2 or 3 people over 100, they have cataract surgery, doesn't will have post-operative iritis. It doesn't mean a matter. If the patient has more than 20,000 over 1 million of people under cataract surgery, they will have post-operative iritis. So this is patient. Thanks for the patient, and these are my reference. And thanks for this opportunity.
Thank you, Niveda.
Thank you.
Over to the judges, please. Dr. Gopi.
Good
Okay.
presentation, Niveda.
Ma'am?
Shall I? Niveda, can you hear me?
Yes, ma'am.
Yeah, good presentation. So I have a very basic question. In iritis, any kind of iritis or rebound iritis, patient complains of pain. What is the reason of pain in uveitis iritis?
Ma'am, the patient is having pain because inflammation or due to infection.
The reason for infection, pain is infection and inflammation. Why does there is pain there?
Because their pupil is constricted, sphincter muscle spasm will happen in iris.
Okay.
Good presentation, Niveda. I just have a couple of questions. What are the other complications you think of post-operatively if they do not follow the drug regimen as prescribed?
Sir, other complication may include endophthalmitis or iridocyclitis, if more glaucoma or cataract.
Okay, you are telling all the common type. Okay. And one more thing is, who do you think is responsible for this, especially when the patient is not compliant with drug usage? Why is it common? It is actually uncommon. The most of the hospitals actually refer them or tell them properly how to taper and things. Who takes this responsibility? Is it the clinician or the patient? Is
Sir,
it
both have to take responsibilities, sir. As per our side, we should monitor their proper follow-up should be given. A proper education should be given to the patient, and the patient should understand clearly so that they will follow properly.
okay? Thank you.
Thank you, sir. Thank you.
Thank you, Niveda.
Thank you, ma'am.
So the next presenter is Ms. Harita Devan, U5. She is able to connect now.
Yes, ma'am.
You can load your presentation, Harita. U5,
Okay.
please.
Ma'am, the screen is visible, ma'am.
Yeah, now it is visible. Go to slideshow mode.
A very happy morning, ma'am and sir. Now I'm going to take a presentation of silent signals unmasking a case of third palsy. Now we move on to the introduction part. The human brain controls many functions through special nerves called cranial nerves. There are 12 pairs of them. These nerves help us see, move our eyes, feel sensation.
Harita, your voice is breaking. We are not able to hear you. No, it's breaking.
Ma'am, now, ma'am.
Yeah. Continue talking.
Okay, ma'am. One of these nerves, the oculomotor nerve, that is the third cranial nerve, is responsible for moving the eye, controlling the eyelid, and adjusting the pupil to light. When this nerve is damaged, it can lead to a third down palsy condition. This can cause difficulty in moving the eye and drooping eyelid, that is ptosis, and abnormal pupil reaction. And next, we move on to the case history of the patient. This is a case of a 55-year-old woman who suddenly developed drooping of her upper eyelid, that is ptosis, and double vision in left eye. Since she has a history of diabetes, high blood pressure, and high cholesterol, doctors initially suspected a problem with her blood supply. These are the clinical findings of this patient. The patient has a visual acuity 6/18 in right eye and 6/12 in left eye, and it can improve 6/6 in right eye and 6/9 in left eye. Let's conjunctiva, cornea, and anterior chamber iris are normal in both eyes. In pupil, right eye 3 mm, and there is no RAPD. In left eye, pupil is 6 mm, fixed and dilated. Both lenses are clear. IOP can be checked at the applanation tonometry at 11 AM. In right eye, 19 mm Hg and left eye, 17 mm Hg. And the head posture and facial feature shows the patient has a normal head posture. However, facial asymmetry is present. Heisenberg test, that is corneal reflex test, right eye shows light reflects the center of the pupil, normal alignment. Left eye, the light reflect is shifted towards the nasal side, indicating 50 degree of exotropia and hypertropia. Cover test indicates to identify the deviation. When the right eye is covered, the left eye moves to the fixation. When the right eye is uncovered, it readjusts to refix it. This suggests secondary deviation is greater than primary deviation. And finally comes to the deviation measurement. Primary deviation shows 15 degrees exotropia and secondary deviation shows 30 degrees exotropia due to a paralytic cause. And this is the diplopic sorting of the patient. Crossed diplopia and vertical separation in increasing in left up and down gaze. And this is the ptosis evaluation of this patient. Marginal reflex distance in right eye 4 mm, in left eye 1 mm. Marginal reflex distance 2 in right eye 5 mm and left eye 5 mm. Palpebral fissure height in right eye 9 mm and in left eye 6 mm. And the LPS function good. And this is the extraocular movements of the patient. It can be used just by broad H test. These are the further investigation of the patient, the fasting blood sugar and postprandial blood sugar and HbA1c, the CT and brain orbit within its limit. And the probable diagnosis can be left eye isolated pupil involving third nerve palsy. And these are all the differential diagnosis of the patient: microvascular ischemic third nerve palsy, comprehensive third nerve palsy, and traumatic third nerve palsy, and last the myasthenia gravis. These are all the management condition of the emergency evaluation. Since pupil is involvement, so posterior communicating artery can be the most dangerous cause, tumors, brainstem lesions, and or comprehensive pathologies. If an aneurysm is found, urgent neurosurgical or endovascular intervention is needed. If no aneurysm is found, further workup, that is vasculopathic workup, at identifying blood glucose level, HbA1c, lipid profile, blood pressure monitoring. And these are all the support measurements, that is observation, prism or patching to manage diplopia and to maintain binocular single vision. Botulinum toxin injection may help to prevent secondary contractures in chronic cases. Strabismus surgery if there is any residual misalignment after recovery. And key differentiation between comprehensive versus ischemic causes. Comprehensive example: aneurysm, tumor, painful, pupil involved. And this is the image of the patient after 1 month follow-up. In this conclusion, the case left eye isolated pupil involving third nerve palsy highlights the critical need for through diagnostic appropriation between difference between ischemic and comprehensive etiologies, the patient's vascular risk factors, that is diabetics, hypertension, and high cholesterol. In this discussion part, the third nerve palsy can have a wide range of underlying causes from benign ischemic even life-threatening aneurysms. Pupil involvement remains a crucial factor in differentiating comprehensive versus ischemic origin. While ischemic third nerve palsy is commonly seen in patients with vascular comorbidities, the possibility of a comprehensive lesion must always be excluded first. Thank you, ma'am.
Thank you, Harita. That was concise. That was concisely put, although it's a long case. Best wishes to you. Over to Ms. Daksha for the question.
Thank you, ma'am.
Hi, Harita. Very good presentation. So my
Thank you,
question
ma'am.
is very basic. What is your role as an optometrist in such cases? If you can just tell it to me in one sentence, what will you do as an optometrist in such cases? Apart from your basic workup.
Can you please repeat this question, ma'am?
As an optometrist, how can you contribute here in such kind of cases? You obviously will do the initial workup, but apart from that, what else can you do? How can you
we
help the
can
patient?
suggest patient. We can do all the
Suggest
comprehensive
what?
examination, ma'am. Like those is
Yeah, that is what that has. Okay. Process evaluation then.
And to explain patients about the seriousness of the high diabetics, high lipid profile, ma'am.
Okay. Anything else?
And also we can suggest for a neurological examination, ma'am, like MRI or CT scan.
Okay.
Nice presentation, Harita.
Thank you, sir.
This is a classical case of having a turnover palsy following maybe uncontrolled diabetes or something. So
Yes,
when
sir.
HbA1c levels, this patient had 7.2, right?
Yes, sir. Yes, sir.
What is the ideal HbA1c levels are expected in maybe patients at the age of 50 or 60? How much is considered to be normal HbA1c levels?
Below 6.5, sir.
Okay, below 6.5 is what? Normal or?
HbA1c, sir, normal.
Okay, how long did this patient take to recover to be a normal without any doses or exotropia?
It takes maximum 3 months to 6 months, sir.
Okay, how long this patient took? I just was my question. Your patient.
1 month. 1 month, sir.
Okay. Follow-up time, how much was the sugar levels? You have any idea? When the patient came
Sir.
for hello, can you hear me?
Yes, sir.
Okay, fine. Thank you, Harita.
Okay, sir.
Thank you, Harita.
Thank you, ma'am.
We'll move on to the next presenter, Ms. Katyayani. Case U14. Can you go to slideshow mode, Katyayani?
Ma'am. Is this visible, ma'am?
Yeah, your screen is visible. Just go to slideshow.
Okay. May I start, ma'am?
Still seems only the slide. Can you go to slideshow mode?
It is in the slideshow mode only, ma'am.
No, not yet, yeah.
It is in the slideshow mode. Is this visible, ma'am?
Your slides are visible. You have to present as a slideshow. Now we are able to see the order of slides too.
Now, ma'am?
Can any of the judges let me know if maybe it is my presentation?
Escape and then.
No, it's not in slideshow.
Is extended mode.
Now, ma'am?
You have to uncheck the presenter view. Escape. There is an option of use presenter view below monitor. Just uncheck that on the right hand side. Yeah, down. Just remove the tick. Yeah, now you present slideshow.
Thank you, sir. Is this visible, sir?
Still no. Okay. I think you can run the slides without slideshow mode. Just give escape and run the slides without wasting time.
I have few animations overlapping between the slides. Is this visible now, sir?
No. Still it is regular.
You should stop. I think you should stop sharing.
And then we share. Try that.
Okay, ma'am. May I share it again, ma'am?
Yeah, share it again. Only the presenter slideshow mode, you share it.
Now, ma'am?
Yeah, we allow her to present this way.
Yeah,
Okay, go ahead. Yeah.
it has some.
It will overlap now.
No, you present without showing it as a slideshow. No other option because there
Okay,
is
sir.
column here.
Okay, sir. Just a minute, sir. 1 minute, sir.
Please start, Karthik.
Okay, sir.
The time has started, Karthiyani.
Good morning to one and all present here. This is Kartini from SRM. I am going to present a case on a holistic approach to progressive chondral dystrophy from early diagnosis to low vision rehabilitation. Introduction. Inherited retinal diseases are genetic condition causing retinal cell degeneration, with cone dystrophy being a progressive disorder leading to vision loss. Pure cone dystrophy is rare. Cone dystrophy is classified into two: stationary, appearing in early childhood and remains stable; progressive, appears in late childhood, worsening gradually and increase rod dystrophy, leading to cone rod dystrophy. Signs and symptoms of cone rod dystrophy varies with its progression rate. Reduced visual acuity, central vision loss, photophobia, color vision deficiency, nyctalopia, metamorphopsia, reduced contrast sensitivity, nystagmus, abnormal pupillary reflex, delayed dark adaptation, peripheral vision loss. Case presentation. This case demonstrates from diagnosis to low vision rehabilitation of a 24-year-old female HRM by profession who had gradual increase in trouble navigating in dark environment, reduced for productivity at work and psychological distress, and photophobia and poor contrast sensitivity observed in over of 8 months. Both eyes known case of unknown retinal dystrophy with high myopic astigmatism and achromatopsia since schooling. Trouble navigating in bright environment using spectacles for distance vision since schooling. Left eye squint surgery and both eyes barrage laser was done. Patient was not comfortable with contact lens. Patient had positive history of first degree consanguinity marriage and history of maternal aunt and uncle with retinal dystrophy unknown. No systemic illness and allergies reported. Clinical findings. Distance visual acuity in unaided state, monocularly 2 by 60 with pinhole 3 by 60, binocularly 2 by 60. For near vision, monocularly and binocularly had N10 at 15 cm. Subjective acceptance had right eye for distance vision -6 diopter spherical, -3.5 DC cross 110. Left eye -7 diopter spherical, -3 diopter DC cross 140. For near vision, both eyes had plano N10 at 15 cm. Intermittent divergent squint and horizontal nystagmus was observed in both eyes. No abnormal head posture and no improvement with further lenses. Anterior segment evaluation and intraocular pressure were within normal limits in both eyes. Fundus examination shows mild bone spicules, attenuated red blood vessels, no glaucomatous cupping, 0.8:1 CDR with temporal disc wear were seen in both eyes. This patient was advised to take full field ERG and pentacam. Full-field ERG reports of both eyes showed mild reduction in photopic response, markedly reduced photopic response and delayed implicit time, and residual cone function indicates achromatopsia. Pentacam findings were within normal limits. Diagnosis. Findings are consistent with non-syndromic progressive chondral dystrophy. This patient was advised to low vision rehabilitation. After with low vision rehabilitation history taking, we are able to understand the patient needs and goals. Eccentric viewing training was found difficult by the patient to adaptation. Patient had adaptation to relative distance magnification since schooling. Relative size magnification on both phone and laptop were introduced. Screen magnifier, enlarged cursor, and text-to-speech software, high contrast mode, enlarged font size were introduced to reduce the digital eye strain and increase the productivity at work. Amber lenses, a peaked cap, umbrella was advised for the mobility for indoor and outdoor. Recommended adjustable task lighting to reduce shadows and improve clarity. This patient was certified as 75% visually impaired, belonging to category 2 under Government of India. Comprehensive counseling and vocational guidance were provided to help the patient adapt to vision loss and manage anxiety. Discussion. Cone rod dystrophy affects 1 in 40,000, typically presenting in early adulthood, with lead to vision loss. With advancement in technology like CSV 2008 in evaluating the condition, which will help in personalized low vision rehabilitation at early stages. Similar to previous study, our low vision management plan of this patient help to achieve their realistic goals but not their patient needs. Early detection and diagnosis plays a crucial role to maintain their individuality. Conclusion. This case emphasizes on the importance of early diagnosis of rod dystrophy and understanding the progression of cone dystrophy is crucial for their rehabilitation. Early intervention by aides to the young adult help to maintain their individuality and early adaptation to the worsening condition. My references and acknowledgement. I would like to thank the patient and their family for their sincere trust and support throughout the case. And I would like to thank Mr. Vivek Sugandhan R, Dr. Aishwarya Radhakrishnan, and Ms. Subhashri from SN who have helped me to present this case, and OATN for the opportunity to present my case. Thank you.
Thank you, Katyayani. We wished we were able to see all the slides. It was truly a holistic approach where, you had included all the departments that we are all posted in and, right from low vision, ERG, everything was covered. I wish you the very best. Over to Daksha ma'am for the question answer session.
As ma'am said, very good present. I mean, the case is very good. It is very well managed. But yeah, we couldn't see the slides, so fine. I'll go to the question. You mentioned a lot of adaptive strategies were given. So could you tell me what adaptive strategies were recommended to this patient?
Ma'am, can you please say again, ma'am? I couldn't hear you.
What were the adaptive strategies recommended to the patient, advised to the patient?
The patient is a 24 female who had adaptation for relative distance magnification since schooling. We were advised to use dome magnifier and portable CCTV for posterior comfort. But the patient did not accept since it is not appealing at the working places. So we advised the patient to use relative size magnification to increase the work productivity and reduce the digital eye strain since she is an HRM who is working with laptop and gadgets every day.
Thank you.
Thank you.
I'm just curious to know, is the first time the patient got diagnosed with progressive cone dystrophy? Because I see 24-year-old should be having this problem since long time, and there is no sign of early diagnosis over here. Do you have any comment on that?
Yes, sir. This case emphasis on the early detection of the retinal dystrophy, but they did not diagnose the case. Since the patient family already had the family history of retinal dystrophy, they were reluctant for not going to any visual aids. From this case, the patient did not find any diagnosis till 24 when it affected her productivity at
Thank you.
the work.
Okay, thank you, Katyayani. The next presenter is Ms. Kritika.
Yes, ma'am.
U16.
Yes.
I request others to mute your mic so that it doesn't disturb the presenters.
Ma'am, is my slide visible?
Kritika, go to slideshow mode.
Yes, ma'am. I have the presentation in slideshow mode, ma'am.
No, it's not visible. You should probably unshare. Go to the presenter mode.
Okay. A second, ma'am.
Or present entire screen. Maybe that will also show you the current screen you're in.
1 second, ma'am. Give me a minute. I'll share the entire screen, ma'am.
Yeah, that should be better.
visible now, ma'am?
Yeah, now it is visible. You remove, you hide that thing which is coming down at the bottom. Yeah.
This one, ma'am.
Yes.
Shall I start, ma'am?
Yes, you can begin. So all the best.
Thank you, ma'am. Good morning, delegates. I'm Kritika, a third year B Optum student from RAO-GOH. Optometric insight into Marfan syndrome, a comparative case analysis. For many patients with Marfan syndrome, their first clue isn't a cardiac emergency, it's a simple complaint, blurry vision. Today, I'll present you two cases that underscores the vital role of optometrist in identifying systemic condition. Marfan syndrome results from an FBN1 gene mutation on chromosome 15, affecting the skeletal, cardiovascular, and ocular systems. The ocular hallmark is bilateral ectopia lentis due to weakened zonules, often leading to a high axial myopia, astigmatism, fluctuating refraction due to lens subluxation, and increased risk of retinal detachment and secondary glaucoma. Let's begin with case 1. A 3-year-old male child presented with progressive defective vision for 6 months. Despite a negative family history, whole exome sequencing confirmed an FBN1 mutation in exon 1, a pathogenic in heterozygous state. Systemic examination revealed arachnodactyly, scoliosis, hyperextensible joints, high arched palate, thin stature, pes planus, genu recurvatum, Steenberg sign, Volker-Moordock sign, pectus carinatum, all classical features of Marfan syndrome. Visual acuity was significantly reduced with right eye at 560 and the left at 612. Near visual acuity N24 in right eye with N12 in left eye. Streak retinoscopy with cycloplegic refraction was performed separately for the phakic and aphakic zones, revealing a fluctuating refractive error due to lens subluxation. It showed a dull reflex and revealed a phakic myopic shift with an aphakic hyperopic correction. Accommodative function was impaired due to zonular instability, contributing to poor near vision and reduced amplitude of accommodation. Patient exhibited compensatory head posture with chin elevation for distance task and depression for near task to optimize vision by aligning with the clearer refractive zone. Slit lamp examination confirmed inferior lens subluxation, zonular dehiscence, iridodonesis, and a deep anterior chamber. While Marfan syndrome usually causes supratemporal lens subluxation, my case is rare. Inferior subluxation in this case suggests a atypical zonular weakness. Fundus examination showed high axial myopia with peripheral lattice degeneration. Moving to case 2, a 24-year-old female with a history of bilateral pars plana vitrectomy and scleral fixated intraocular lens implantation in 2016. She presented with flashes and diplopia in the right eye for a month. Examination showed subluxated SF IOL in the right eye, sluggish pupil reaction, iridodonesis, and a hyperemic disc with blurred margin. B-scan findings included IOL reverberations in the anterior vitreous, incomplete PVD, and vitreous condensation sheet. Case 1 met the diagnostic criteria for Marfan syndrome based on ectopia lentis, FBN1 mutation, and a systemic score of more than 7, considering the systemic features. Pre-surgical management included lensectomy with SF-IOL implantation to correct visual impairment. For case 2, the focus was on IOL removal with secondary IOL implantation, which can be an AC IOL or an iris claw implanted, and low vision aids to optimize residual vision. Post-op, both of these patients require rigorous fundus monitoring for retinal detachment and secondary glaucoma. Comparing both the cases, we see early versus late surgical intervention outcomes. Case 1 had subluxated crystalline lens, while case 2 had a subluxated SF IOL, highlighting the long-term post-surgical risk. Fundus findings differ, lattice degeneration in case 1 versus pigmentary changes in case 2. Visually evoked potential showed mild prolongation in case 2, indicating potential optic nerve involvement. Key differential diagnoses considered were homocystinuria, Weil-Marchesani syndrome, Heeler-Danlos syndrome, and aniridia. Okay, Marfan syndrome presents various ocular features, to name a few: megalocornea, iridodonesis, a flatter cornea, and retinal detachment risk. In the first case presented, the infant was brought to the hospital solely for defective vision. Before that, he wasn't reported to have, the parents were not aware of his Marfan syndrome. Only after an eye examination was he referred for systemic evaluation, leading to the diagnosis of Marfan syndrome. So from an optometric perspective, key consideration includes retinoscopic finding, where no target reflex or high plus power indicates subluxation, A-scan findings where spike pattern confirms lens displacement, post-surgical aphakic correction and high axial myopia and astigmatism demand customized optical correction. To name a few, high index lenses with aspheric design, slab of prism correction, scleral or hybrid lenses, multifocal RGP lenses, low vision aids for improving residual vision. Since Marfan syndrome affects multiple systems, optometrists play a crucial role in referring for genetic, cardiac, and orthopedic evaluation. Literature references studies show that Marfan-related refractive errors can be managed non-surgically with specialized optical correction. Research
1
also
minute left.
Yes, ma'am. Research also confirms SF-IOL as an effective surgical intervention, but highlights potential complications like IOL subluxation, vitreous condensation, and optic nerve changes. To conclude, early detection of ectopia lentis is crucial for diagnosing Marfan syndrome. As optometrists, we must be vigilant in detecting systemic disorders through ocular signs and play a pivotal role in pre and post-surgical vision rehabilitation. I would like to express my gratitude to RAOGOH, my professors and mentors for guiding me in this case study. Thanks OATN for this opportunity. Thank you for your time. Thank you.
Thank you, Kritika. That was a very good presentation.
Thank you, ma'am.
To Daksha ma'am for the questions.
Hi, Kritika. Nice presentation.
Thank you, ma'am.
Yeah, so my question to you is what is the reason for secondary glaucoma in such cases? How does secondary glaucoma step in?
Okay, secondary glaucoma can cause the type of secondary glaucoma in this is can be due to lens-induced glaucoma like phacolytic and phacomorphic. It is due to lens subluxation, pupillary block, or angle abnormalities leading to increased intracranial pressure, which may in turn lead to secondary glaucoma.
Thank you.
Hi, Kritika. Nice
Hello,
person.
sir. Thank you, sir.
I'm just curious to know why did you take the call of doing DEP in this case? The second case, I think, why was the decision of doing DEP was done?
Yes, sir. Visually evoked potential was done because we had optic nerve involvement because AP report showed there's a field defect.
And one more question is like there was intraocular pressure of only 9 mm Hg in the left eye, which had the SF-IOL displacement. So if not treated, what do you think it is going to lead?
As ma'am said, it may lead to secondary glaucoma due to pupillary block. The lens subluxation could cause angle closure. It may affect the angle, and we may get increased intracranial pressure secondary to it, sir.
But the intraocular pressure is only 9 mm Hg.
No, if it is not treated, maybe we would get the complication of it, sir.
Any chance of hypotony here?
No, sir.
Thank you.
Thank you, sir.
The next presenter is Mr. Shakti Vale, U18.
Yes, ma'am. Am I audible, ma'am?
Yeah, we can hear you. Upload your presentation. Please go to slideshow mode.
Yeah, is my screen visible, ma'am?
Yes, you're good to go, yeah.
Yeah, okay. Very good morning, everyone. Myself, Shaktivel, pursuing third year BSc Optometry at Dr. Agarwal's Institute of Optometry, Chennai. Today, my case is on trauma-related bullous keratopathy. Bullous keratopathy is a severe corneal condition characterized by epithelial edema and formation of bullae, often leading to pain, visual disturbances, and in advanced stages, blindness. Trauma-induced bullous keratopathy is rare significant in India due to high ocular trauma rates. So about the patient, a 43-year-old male patient came up with the chief complaints of redness, pain, watering, and discharge since 10 days in the right eye, and no other specific complaints in the both eyes. Ocular history of surgery since 33 years in the right eye and history of glasses in both eyes. His general health revealed that he has diabetes mellitus and since 2 years and is under medication. Family history was not contributory. Recent investigation was nil, and current medication, he is under medication for diabetes mellitus, and he is not aware of any allergies. And his PGP was minus 5.5 with minus 2 DC across 80 in the right eye with a vision of 6 by 18 and N8. In left eye, his PGP was plus 0.25 with a 6.6 vision and an N6. And add of plus 1 diopters in both eyes. Visual acuity was 6 by 18 with no improvement in pinhole in the right eye and 6 by 6 with N6 in the left eye. Refraction was not done and EOM was full free painless and pupils were reacting to light and no RAPD. IOP using an NCT was OD 15 mmHg and OS 14 mmHg at 12:46 p.m. On slit lamp examination, it revealed that circumciliary congestion in the right eye and haptic erosion at 11 o'clock in the right eye. And pupils were reacting to light, but they are sluggish. And both eyes were revealed that anterior chamber cells and presence of pseudophakia, that is anterior chamber IOL in the right eye. So this is the image of the haptic erosion at 11 o'clock. On fundus examination, the fundus was nearly normal. Diagnosis and management. Diagnosed with pseudophakia and anterior chamber IOL with haptic erosion. Advice. He was advised to undergo clinical photography, A scan, syringing, and B scan. Planned surgical intervention included wound exploration, IOL explantation, and secondary IOL implantation with glued IOL fixation. A scleral patch graft was considered intraoperatively to restore ocular integrity and enhance prognosis. Follow-ups and visits. Follow-up 1 post-surgery. The patient developed severe sclerokeratitis, deep anterior chamber, decibel membrane folds, eyelid swelling, stromal edema with bullae, and was diagnosed with pachymetric bullous keratopathy. Uncorrected visual acuity declined to 1 by 60. Follow-up 2 underwent PDEK, that is phacoemulsification with decibel membrane endothelial keratoplasty. His post-operative uncorrected visual acuity improved to 3 by 60. And these are the image of the pre-operative and post-operative. Follow-up 3 months later. Uncorrected visual acuity fluctuated between 1 by 60 and 6 by 60 with recurrent epithelial defects. Graft failure confirmed that hazy graft corneal scarring and endothelial haze. Management, intensive lubrication to promote epithelial healing, topical steroid adjusted based on inflammation, IOP control with anti-glaucoma drugs. Follow-up 1 year later. Persistent issues, SFIOL in place, persistent corneal edema, grade 4 Fuchs endothelial dystrophy, peripheral iridectomy at 3 o'clock, iris schwannoma, peripheral anterior synechiae, and uncorrected visual acuity of 5 by 60. The management was continued use of topical steroid and anti-glaucoma medications, considerations of penetrating keratoplasty or repeat endothelial keratoplasty for visual rehabilitation, long-term follow-up for endothelial health and IOP monitoring. The discussion was the presented case of bullous keratopathy following ocular trauma and AC IOL implantation highlights challenges in surgical management. Compared to Indian reports where bullous keratopathy commonly follows cataract surgery, our case required multiple interventions including PDEK and SFIOL due to graft failure. The complexity of managing trauma-induced bullous keratopathy underscores the need for individualized treatment approaches and vigilant long-term monitoring to address recurrent complications. Despite advanced surgical techniques, persistent corneal edema, scarring, and endothelial decomposition often limit visual recovery in such cases. Conclusion. The case underscores the complexity of treating trauma-induced ocular complication. Despite multiple surgical intervention, visual recovery remained limited, similar to cases with chronic endothelial dysfunction. Similar to other reported cases, persistent complication posed significant challenges in long-term management. Corneal transplantation remains a viable treatment option for advanced cases of bullous keratopathy, emphasizing the need for careful patient selection and long-term post-operative monitoring. These are my references. Thank you. Thank you, OATN, for this opportunity. Thank you, everyone. Thank you.
Thank you, Shaktivel. Truly, I should feel sympathetic or empathetic with the patient. Over to Daksha for the question answers.
Thank you. A good presentation, Shaktivel.
Thank you, ma'am.
Just curious to know why was this patient came with an ACIOL, right? Any idea why there was no PCIOL fixed at that point? Was that asked or any details on that?
No, ma'am. We have no details on that, ma'am.
Okay, you don't know why that was. Okay, could you tell me what could be the reason of not putting on a PCIOL?
Ma'am, the lens capsule was not sufficient to hold the PCIOL, ma'am.
Okay, you asked the patient. Did you confirm this or you're telling? You're giving this as an answer.
No, ma'am, we confirmed and we are saying, ma'am, the lens capsule was not enough to hold the PCIOL.
Okay. Okay, fine, fine.
So you had mentioned corneal transplantation is an option over here. How do you think the aspect on the corneal graft rejection in this case, because the patient has already undergone anterior chamber IOL implantation? And
Sir, could you please repeat, sir? The
so
voice is breaking a little bit.
treating corneal rejection, graft rejection,
Yes, sir.
there is a corneal transplantation done.
Yes, sir. There is a graft rejection, sir.
Okay, thank you.
Thank you, sir.
Thank you, Shaktivel.
Thank you, ma'am. Thank you.
The next presenter is Mr. Alan Christopher, case ID U30.
Yes, ma'am. Can I share my screen, ma'am?
Yes, yes, please. Slideshow.
Whether it is visible, ma'am?
Yes, it is visible. You're good to go.
A pleasant good afternoon to one and all present here in this virtual presentation. My name is Alan Christopher from third year BSc Optometry from Lotus Institute of Health Sciences and Management. And I'm here to present a case on monocular solar retinopathy and laminar hole. First of all, let's have an intro on solar retinopathy and laminar hole. Solar retinopathy is a photochemical toxicity causing resultant injury to the retinal tissues. Yes, ma'am. Can I present, ma'am?
The timer is going on.
Okay. Solar retinopathy is a photochemical toxicity causing resultant injury to retinal tissue, usually occurring at the fovea. Primary cause for solar retinopathy is exposure to intense light conditions like solar ellipse viewing, and people under occupations like arc welding without personal protective equipment are prone to these conditions. And worldwide prevalence rate of solar retinopathy is 0.01%, according to survey taken between 2012 and 2021. Males are more affected than females. And laminar hole is a retinal disorder condition causing partial thickness defect in the inner layer of retina and usually associated along with the conditions of vitreomacular tractions and cystoid macular edema. The prevalence ranges from 1.1% to 3.6% and possibly affecting after 50 years of age. Let's move on to the case history. Here, a 73-year-old female came to the hospital having complaint of bilateral diminution of vision and watering for past 3 months. And past ocular history reveal patient is pseudophakic since 3 years. And past medical history, the patient is having systemic illness of diabetic mellitus, hypertension, hypercholesterolemia since 10 years, and urinary bladder stone since 9 years, and seizures since 4 years. And patient is under medication for all these systemic conditions. And patient doesn't take any current drops for this ocular complaint, and the patient is not aware of his allergic history. And clinical finding and diagnosis reveal that unaided vision of the patient is 6.9 strain in both eyes for distance and for near N10 at 33 centimeter. And acceptance distance, the patient does not accept any power for distance, no improvement with pinhole. And for near, patient accept plus 2.75 dioptric sphere, and which improve their vision at N6. And these are the keratometric readings. An intraocular pressure value of this patient is 18 in right eye and 17 in left eye. The OCT revealed that the patient is having solar retinopathy in his right eye and laminar hole with foveal cyst in left eye. Management and treatment. The optimum way to avoid the solar retinopathy condition is to avoid exposure to intense light conditions like solar ellipse gauging and avoid eye beam lasers for this condition. Treatment, the patient's vision was stable, so there was no treatment and advice for this conditions. And these were the discussed. The fundus usually in most of the cases of solar retinopathy, the fovea have yellowish white spot in it, and there is no proven treatment for the solar retinopathy. In some cases, steroids are tried, and pars plana vitrectomy is one of the surgical option for laminar hole. And after photochemical injury of 2 to 3 weeks, the patient can develop laminar hole in some cases. That's why in this case, the patient is having a laminar hole in one eye and solar retinopathy in another eye. And the hemetropic and hyperopics are at higher risk. Early diagnosis and follow-up is important for this patient to avoid permanent vision loss. And aphakic and pseudophakic are at risk of developing solar retinopathy. These are the articles and literatures I referred from. Thank you all for giving this opportunity, and thank you OATN for for helping us to grow and learn. Thank you.
Thank you, Alan. That was a very good presentation.
Thank you.
Over to Daksha for the questions.
Hi, Alan. Good presentation.
Thank you, ma'am.
My question is, which layer of retina or around where, which area exactly in the retina does solar retinopathy affect?
Usually, the solar retinopathy affect photo receptor layers, RPE, but in this case, the RPE is not much affected in this patient, ma'am. So vision is more normal.
Oh, thank you.
Thank you.
Hi.
Yes, sir.
Right. Alan, can you tell how did you find that patient really had solar retinopathy? Which stage of visit the patient reported they had exposure to sunlight or something?
The patient have done cataract surgery in our hospital, sir. Patient came with a complaint of diminution of vision. The OCT has been taken for this patient that relieved solar retinopathy.
No, whether there was any record from the patient history aspect, I'm asking.
You asking for occupation?
No, not occupation. Whether the patient told that they had exposure to like sunlight exposure and things.
No, sir. The patient occupation is farmer. Is not at work now.
Okay.
So this was a finding from this.
Thank you.
Thank you, sir. Thank you, ma'am.
Thank you, Alan. I request Ms. Darshini To load her presentation, U31 is your case ID.
Yes, ma'am.
Okay. You can start. Darshini, are you there? We can't hear you. Darshini? Darshini, we are not able to hear you. Your voice is muted, yeah? Unmute yourself and talk. Darshini, can you hear me?
Host can unmute her.
Huh?
Host can unmute.
Can you hear me, ma'am?
Yes, now I can hear you. You can go ahead with your presentation.
Can you see the screen, ma'am?
Yes.
Okay. Okay, ma'am. Good morning, good afternoon, ma'am, and good afternoon, sir.
You're losing time. What happened? Shall we move on to the
Yes,
next?
ma'am, we are connecting, ma'am.
It's getting
No,
delayed,
ma'am, no,
ma'am.
ma'am. Please start. Now, can you visible, ma'am?
Yeah. Go to slideshow mode, please.
Can you see the slide, ma'am?
Yes, I
Okay.
can see this. Go to slideshow
Okay.
mode.
Now, ma'am? Can you see, ma'am?
Slideshow mode is not working. View. Share entire screen. Please share entire screen.
Okay, ma'am. Now, can you see, ma'am?
Yes.
Shall I start?
Yeah, please go ahead.
Okay. Good afternoon, ma'am, and good afternoon, sir. My case presentation is based on the topic of band-shaped keratopathy. So what is band-shaped keratopathy? It is a corneal degenerative disorder which is characterized by calcium deposition in the superficial corneal layers. And the main cause, it may be chronic ocular inflammation and systemic conditions like hypercalcemia, chronic renal failure, or prolonged exposure to certain eye drops, which contains phosphate in it. And my case history was a patient, a 40-year-old female patient, came with the complaint of reduced visual acuity, foreign body sensation, and a glass sensitivity in both the eyes. Her complaint was in both the eyes. And the history was taken as she has no surgical or medical history and no history of any systemic diseases, and no allergies were also known. And the clinical examination in which visual acuity was first done,
With us, the right eye as 636 and the left eye as 624 partial. With pinhole, it is improving to just one line as 618 right eye, left eye is 612. She has no history of PG used. And the duct patency is both eyes pattern, and the intraocular pressure is in right eye it is 17 mm Hg and in left eye it is 15 mm Hg. So in the slit lamp findings in both the eyes where the EOM was full and lids and conjunctiva was also normal and sclera was also normal. In cornea, there is a presence of horizontally distributed calcific deposits in the interparallel region, which extends from the medial canthus to the lateral canthus. And the anterior chamber was also normal depth and clear, and iris and pupil reaction was also normal, and no RIPD was seen. And the fundus examination where media is clear and disc is also normal, and cup to disc ratio is 0.3:1. And the investigations were done as corneal scraping report. There is no signs of infection were seen when the cells in the cornea was taken and it is given to the lab, and they found that there were no infections like bacterial or fungal. And the anterior segment photography through slit lamp, we can see the band-shaped calcific deposits. Through the anterior segment OCT, it confirms that the calcium deposit is in the Bowman's layer. And the treatment provided is EDTA chelation therapy, along with these supportive care artificial tears, anterior segment evaluation, and follow-up monitoring. So the treatment is based on the severity of the corneal calcification and associated. Coming to the management, the conservative management is for the mild cases where we use lubricating eye drops, that is the artificial tears, to maintain the corneal hydration. Whereas hypertonic saline drops or ointment can also be used in reducing the epithelial edema, and soft contact lenses is also used to protect the cornea and to improve the visual comfort. Next is the medical management, where chelation therapy with diamond tetracetic acid. What is chelation therapy is, first thing, the topical anesthesia is given to the patient and the epithelial debridement is done. Then after that, the application of EDTA is given to the patient. It is given for some time until it gets bind to the calcium, then it gets loosened through it. After that, it is removed, scraped off through the knife, and it is irrigated with the debris to remove the excess of the calcium deposits there. Then the bandage contact lens is placed over that to prevent the cornea. After that, the topical antibiotics is usually given to prevent the secondary infection. Topical steroids is also given. And surgical management, it is usually performed in the severe cases where superficial keratectomy is performed, in which the calcium, if the chelation therapy is not insufficient, then the superficial keratectomy is performed, where the outer layer of the cornea, especially the epithelial and the Bowman's layer, is removed to treat this condition. And excimer laser phototherapeutic keratectomy is that where it is usually performed in cases of deep calcium deposits. We use the laser to remove the affected corneal tissue and improve its transparency. In amniotic membrane transplantation was also done in the severe cases where still the epithelium defect is found. In that, the piece of amniotic membrane, just the inner layer of the placenta is taken and it is usually grafted over the layer which has a property to help the growth of the epithelium. So amniotic membrane transplantation may also be performed. In the deep cases, the keratoplasty, which is the end stage, the corneal transplantation may also be performed. And my discussion and conclusion is that BSK, it is a progressive condition that it requires early intervention for optimal visual prognosis. That is, if a timely diagnosis and appropriate treatment is given, we can reduce its progression and improve the visual acuity. Thank you, ma'am.
Good one, yeah. To Daksha, please.
And Darshini, nice, well presented. So what could be, you said the eye drops can cause, few of the eye drops can cause BSK, band-shaped keratopathy. Could you name a couple of eye drops? Or what does the eye drop contain? Anything?
Eye drop that contain calcium, phosphate content. Eye drops that contain phosphate content in it can cause.
Which ones? Which ones? That's what I'm asking. Name just one of them. Name just one of it.
Which contain phosphate.
Which eye drops? Yeah.
Dexamethasone, ma'am.
Okay, fine. Thank you.
Rashmi, good presentation. What is unique or novel in this case?
Sir,
What is something unique or novel in this case?
Dr. Gopi, your voice is not clear.
Can you hear me better? What is unique?
yes, sir, now I can hear you.
What is the uniqueness in this case? Can you explain?
What is the uniqueness in case? Yes, sir. It is not a common disorder which comes to all the patients. It is a condition which occurs due to some of the eye drops, continuous use of eye drops that contains phosphate in it, or due to the chronic ocular conditions. So it is not a common condition.
The fan shaped keratopathy is not common.
Yeah.
Thank you.
Thank you, Dr. Gopi. Thank you, Ms. Darshini. We move on to Ms.
Thank you, ma'am.
Yeah. Ms. Deepika, you can load your presentation. Case ID U33. Ms. Deepika, are you there?
Yes, ma'am.
Oh, you're from the same college, is it? Okay.
Yes, ma'am. Ma'am, is my slide visible?
Yes, it is visible. Can you remove that, the key when you have this height thing, right? You can click on that. So your time starts now.
Okay. Shall I start?
Yes, you can begin. U33.
Yes, ma'am.
Okay.
So good afternoon to one and all present here. Myself, Deepika. I'm going to present you guys the topic on about chemical eye injury. So my topic covers about the introduction and case history and diagnosis and management and clinical findings and treatment. So moving on to the introduction, chemical eye injuries are ophthalmic emergencies that require immediate management and treatment to prevent vision loss. So it is categorized into alkali and acid burns. Alkaline consists of the toiletries which use on our day-to-day life, such as sodium hypochlorite, and prolonged use can affect the cornea, conjunctiva, and deeper structures. So moving on to the case history, my patient is a middle-aged person with a complaint of exposure to chemical substance, that is H2SO4. Sulfuric acid is splashed in his eye with the complaint of redness, epiphora, and blurred vision. So the medical history is diabetes and hypertension and asthma, no other drug allergies. Clinical findings is visual acuity is reduced up to 3/60 and below. And the slit lamp findings, we can see that corneal epithelial defect and stromal haze and conjunctival congestion and chemosis. Is reduced, and OCT findings we see corneal edema and thinning in affected areas. So other findings includes corneal straining and further investigations. We are moving on to corneal scraping report and anterior segment photograph and anterior segment OCT. So management is immediate management, copious irrigation with normal saline water to remove the chemical and minimize the further damage. And topical antibiotics include T-doxycycline 150 mg and T vitamin C. Cycloplegic drugs, we can use topicamide eye drops. And artificial tears, we use Lubrex eye drops and Lacry gel eye ointment. And
For prolonged long-term management, we can tell the patient for regular follow-up checkups, and if in case of severe, we can use corneal transplantation. So my discussion and conclusion include using of medication that we provide, such as moxifloxacin and Lubrex and tropicamide, and thank you.
Thank you, Deepika. You seem to be quite happy in presenting your case. Yeah. Okay. Over to Ms. Daksha for the question and answers.
Deepika, so my question is, we all know alkali, so this was an acid burn, and we know alkali burns are more severe. So could you tell me the reason why is alkali burn more severe than an acid burn?
It has high pH containing than acids.
Yeah, so
it can progress and can cause severe vision loss than acids.
Yeah, but what is the reason for more vision loss? That is my question. Okay, fine.
Hey, what is the patient occupation? Do you know? What is the patient occupation?
Sanitation worker.
What?
Sanitation worker, sir.
Okay. And the patient was not using any protective equipments. Did you ask in the history?
So can you repeat the again?
No, whether the patient was using any personal protective equipments during their work?
No, sir.
Was it documented? Was it asked during the history?
Yes, sir.
Details in the case report which you have submitted. Okay, thank you.
Thank you, sir.
Over to you, Preetha.
Sorry, I didn't unmute and I was talking. Thank you, Ms. Deepika. We have Ms. Haripriya coming up next. Case number U34. Haripriya?
Yes, ma'am.
Okay, you can upload your presentation.
Is it visible, ma'am?
Yes, it's visible. Please check if you can go to slideshow mode. Yeah.
Myself, I'm Priya from Exam. Now I'm going to move on to the case of failed penetrating keratoplasty with Boris keratopathy. So penetrating keratoplasty is a technique of performing full thickness transplantation in which diseased cornea is replaced with clear healthy donor. In which the clinical indications include corneal dystrophy, sexatia, depression, scar, keratopathy, and graft rejection. And the complications include graft rejection, graft failure, secondary glaucoma with corneal neovascularization, endophthalmitis or panoplasmitis. So again, bullous keratopathy is characterized by corneal edema with subepithelial bullae due to endothelial cell loss and decomposition, which leads to failure of maintaining the dehydrated state of cornea, which leads to loss of transparency and reduced vision. Moving on to the case, a 35-year-old female presented with a complaint of severe eye pain only for 1 week, and there were no other often complaints. Patient had a history of accidental trauma of the stick 30 years ago at the age of 5 in right eye. So PK was done twice, once when the accident occurred, which was 30 years ago, and the next one was 2 years back. In left eye, there were no such histories. And patient used Combigan eye drop in right eye alone for 2 years, but discontinued it 3 months back, and no issue of spectacles or any other ocular surgeries. General health included diabetes for 2 years, and she was under medication. Recent investigation included random blood glucose test, which was high and which was taken 5 months back. Other issues remained insignificant. The distal visual acuity was hand movements with PLPR in the right eye, with six parts and no increment in dimple in left eye. Near vision was N36 in the right eye and N6 in left eye. Auto refractometer was deferred as the patient was in a hurry to move on to the next thing. An IOP was measured with NCT at 1:22 p.m. and there was no obturation in right eye and 13 mm Hg in the left eye. Slit-lamp findings revealed wrong upper and lower lid glasses with 16 intact PK sutures and corneal neovascularization. Corneal edema with opacification and corneal bullae was present. AC depth, iris and lens filters were unclear due to the opacification. Left eye slit-lamp was normal. Only nasal pterygium was noted, in which 1 mm corneal infiltration was seen. Fundus examination, there was no view in right eye and left eye was within normal limit. So B scan was done in right eye, which revealed that the retina was attached and with the axial length was bigger. So axial proptosis was seen. So the diagnosis, right eye was diagnosed with failed PK photos chemotherapy and left eye was diagnosed with pterygium. So management, first the patient was advised to reduce IOP. So Combigan eye drops were used previously by the patient, but she felt that it was expensive, so the eye drops was changed to Demolar eye drops, and Combigan tablet was given to reduce the pain, and Lumex eye drops was given to reduce the risk of dry eye due to proptosis. So once the IOP is reduced, she was planned with PK. Patient also inquired about the contact lens option for the cosmetic reasons, but contact lens option was not recommended due to the risk of dry eye discussion. In our case, NCT was performed, but IOP can't be measured due to the opacification and no applanation. So, and on the other hand, the standard Goldman applanation tonometer is not considered the most reliable method due to the altered corneal thickness and curvature, because GAT can underestimate the IOP in such cases. So why we are talking about IOP is the incidence of post-PK glaucoma is 41%, and the incidence of glaucoma post-repeat PK is even more higher, which is around 60%. So early survival rate of graft following PK are elevated, but there is a significant over-prolonged duration with less than 50% of grafts sustained viable after 20 years. because of late complications like graft failure. While repeat PK ensures high long-term graft survival, EK archives produces superior visual outcomes with reduced complication, including the risk of lowering the graft rejection, because only partial cornea is transplanted in EK. Simultaneous now for the treatment option, simultaneous use of immunosuppressive treatment and anti-glaucoma medication requires regular follow-up to minimize potential drug interaction, because corticosteroids used as immunosuppressants can elevate the IOP. So regular follow-up is necessary for early intervention and to minimize the complications. In our case, corneal vascularization is seen in the grafted cornea, which is often a poor prognostic indicator of PK. And bullous keratopathy is often treated with corneal transplantation. So the extent of affected cornea was more, so PK was chosen as the treatment option. So to conclude, despite the high success rate, PK faces challenges such as immune rejection and endothelial cell loss and graft failure over time. Careful patient selection, post-operative management, advances in immunosuppressive therapies, and regular follow-ups are essential in minimizing the complications to facilitate early intervention and to enhance the long-term surgical outcomes. These are my references. I thank the patient for her cooperation in becoming the ophthalmology and Dr. Aishwarya Radhakrishnan for her guidance and OATN for giving me this opportunity. Thank you.
Thank you, Haripriya. That is a good presentation. On to Daksha ma'am for the question and answer session.
Haripriya, well presented. So my question is, this particular patient, they have not removed the sutures. Maybe the reason was not also documented. Could you tell me when are sutures removed in PK patient? Approximately, or is there a timeline when the sutures are removed?
I'm not sure about that now.
Okay, fine. Yeah, Dr. Gopi, you can go ahead.
Yeah, Haripriya, thank you for the good presentation. Can you tell me what is the mechanism of action of timolol? Because that's what the patient got advised. What is the mechanism of action?
Mechanism option of timolol is to lower the IOP by reducing the production of aqueous humor, sir.
Okay, thank you.
Thank you, sir.
Thank you, Haripriya. Next is Ms. Madhumita, U36.
Can you hear me now?
Yes. Yes, Madhumita, you can load your presentation.
Can you see my screen now?
Yeah, I can see your screen. Yeah, okay, fine.
Good afternoon to everyone. I'll be presenting a case on vitreomacular traction caused by proliferative diabetic retinopathy. VMT occurs when vitreous partially separates from the retina, but it will be attached to the macula alone. While this is rare, the underlying causes might be ARMD and DR. PDR will also lead to VMT due to the formation of new blood vessels, that is neovascularization, along with the fibrous tissue development, that is proliferative fibrovascularization, can cause adhesion between the vitreous and macula. When the vitreous attempts to separate from the retina, these adhesion will create the traction, resulting in the distortion, and it will potentially affect the vision. The common signs are decreased vision, metamorphopsia, photopsia, micropsia, and the symptoms includes retinal surface thickening, foveal pseudosis, cystoid macular edema, macular schisis, or macular detachment. In this first reference image, you can see the foveal cyst or pseudocyst over here, and in this one, you can see the cyst lines in this image. The patient is a 47-year-old male. He came with a complaint of distorted vision since 9 months. His previous ocular history, he was not using any spectacles, contact lens, or he has not been facing any trauma. He's a known case of PDR. So he has undergone pan-retinal photocoagulation for PDR 5 months ago. His current PG in right eye was plus 2.5 diopters and left eye plus 3, and add of plus 1.75 diopters. The best corrected visual acuity for distance is 6/24, and for right eye it's 2/60 with no improvement in pinhole. For near it is N18 and N36. His general health, he was a known case of diabetes, hypercholesterolemia, and PDR. His blood sugar levels were not under control. It was orally said by the patient itself, and the rest of the history were normal. The slit lamp evaluation showed normal
were within the normal limits, and IOP was also normal. In fundus examination in the right eye, the previous PRP laser scans were visible, and there was fibrovascular proliferation at the disc, and the cup disc ratio was normal, and there was vitreous hemorrhages in both the eyes. In the left eye, there was opening in posterior hyaloid phase. This is the OCT image of the patient. In the right eye, you can see the hemorrhages causing the shadows. And in the left eye, there are severe tractional vitreomacular traction. And the patient is diagnosed with both eye PDR and in left eye VM. The treatment given for the patient because of the severe structural damage and visual impairment, it was pars plana vitrectomy with gas bubble injection. And after a review of 4 weeks, his visual progression was also good, and he showed a good improvement in the left eye of 6/36 parts. He has gone from 2/60 to 6/36 parts. The patient complained about the gas bubble, that is the fish egg phenomenon in his field of vision, but the counseling regarding how it will disappear after a few days, and the counseling regarding how they should behave and how they should do regular activities during this period of recovery was clearly given. And the other management options, if the observation of the patient is really important, if it is mild VMP or VMA, vitreomacular adhesion, because the spontaneous separation may occur in milder cases, and pharmacological vitreolysis with an injection of oxyplasmin for smaller VMT and macular holes was given. And pars plana vitrectomy is the most effective in relieving VMT. It has higher percentage of recovery. And in similar other cases where the VMT was less smaller, the oxyplasmin has shown effectiveness, but in larger VMTs, it was not really that helpful. And in pars plana vitrectomy was really suggested. And in pharmacological vitreolysis, the intravitreal injection of oxyplasmin showed 25% of success rate, but it is really helpful more than this in macular hole with a success rate of 40%. And I would like to conclude with the importance of managing the systemic diseases because the patient was not really cooperative in taking diabetic medicines. And globally, 7% of people with diabetes are affected by proliferative diabetic retinopathy. Therefore, it is really important to do early screening, prevention, and treatment even before it goes to the severe stage. And I conclude that surgical intervention such as PPV has the best and high chance of vision improvement progress comparing to others in VMP. These are my references. Thank you.
Thank you, Madhumita. I request Daksha ma'am to handle the questions.
A nice presentation, Madhumita. So, very basic question. What is your role in this kind of a case? How you can help this patient as an optometrist?
As an optometrist, it is in diagnostic test, we can run the diagnostic test, and we can give counseling to the patients, and also in checking the metamorphosis with the Amsler gauge, it is really important for the optometrist to do. And regular monitoring and screening can be done by the optometrist. And a post-operative monitoring of the progression of vision or any visual outcomes.
Thank you. You can ask the question.
Thank you. You can go to the next presentation.
Gopi?
don't have any questions.
You didn't have any questions? Okay, fine. So the next presenter is Ms. Latika, U40.
Yes, ma'am. Shall I start my screen?
Yes, you can. Slideshow
Is it
mode.
visible?
Yes, it is visible. Go to slideshow mode, please. Yes. Your time starts now.
Good afternoon, all. Myself, Latika J, pursuing my third year BA Optum at Dr. Rogal's Institute of Optometry, Chennai. Today's presentation topic of mine is eyes in conflict, Duane syndrome, and retinitis pigmentosa. The introduction. Duane syndrome is a congenital ocular motility disorder caused by abnormal development of sixth cranial nerve or its innervation, resulting in restricted eye movement. Retinitis pigmentosa, a hereditary retinal condition, leads to progressive vision loss, often culminating in central vision impairment. The co-occurrence of both Duane syndrome and RP is extremely rare. Case report. A 62-year-old female patient presented with the chief complaint of redness, pain around the orbit since 3 months in the left eye, with no other specific ocular complaints in both the eye. The previous ocular history of the patient revealed the patient had a history of retinitis pigmentosa since 19 years, along with retinal detachment, macular degeneration in both the eye. The patient also had a history of Duane syndrome and YAG-PI 20 years ago in the left eye, along with a history of cataract surgery done in right eye since 18 years. General health. The patient had a history of diabetes and a history of spinal surgery 6 months ago. Family history not contributory. Recent investigations nil. The current medications of the patients are the patient is under medication for diabetes mellitus, allergies not aware of any. Ocular examination. The PGP of the patient is not brought. The uncorrected visual acuity of the patient is perception of light absent in both the eye. Refraction differed. The extraocular movement showed a full free painless movement in the right eye and abduction restricted along with narrowing of palpebral vision on adduction in the left eye. Pupils are slightly sluggish, response to light in both the eye. IOP using NCT at 9:26 a.m. revealed 14 mm Hg in the right eye and 13 mm Hg in the left eye. The slit lamp examination shows circumciliary conjunction of the conjunctiva in both the eye, along with corneal ulcer with descendus membrane folds in the left eye. Pupils are reacting to light but sluggish in both the eyes. Presence of antechamber flares in both the eyes are seen. The right eye's lens is pseudophakic. Fundus examination. The fundus examination revealed hazy media in both the eye, along with optic atrophy, attenuated blood vessels, and bony specules in both the eye. Clinical findings and diagnosis. The left eye revealed unspecified corneal ulcer, and both the eye revealed pigmented retinal dystrophy in both the eye, and Duane's retraction syndrome in the left eye. The patient was advised with Vicomax Formira Orbin homemade eye drops, along with Supernac omicin tablets and capsules. Follow-up visits. The first week of the follow-up, the patient showed good progress with treatment with significant corneal changes. Follow-up 2, 4 months late. 4 months later, the right eye developed nystagmus, corneal opacity, and absent direct and consensual pupillary reflexes. The EOM movement were full, but visual decline continued. Advice. The patient was advised for referral of neuroimaging and autoimmune workup. Follow-up 3. 8 months later, the patient presented with severe pain, redness, headache, and inability to open her eyes. Sorry, ma'am.
Please go ahead. Nothing happened.
The patient presented with severe pain, redness, headache, and an inability to open her eyes due to pain. The superior scleral thinning noted, recurrent corneal ulcer with opacity with active infiltrates, descendus membrane folds, and edema is seen.
hence diagnosed as neuromyelitis optica with severe visual impairment due to complex interplay of RP, corneal disease, and NMO. Neuromyelitis optica, also known as Devic disease, is an autoimmune disorder where the body's immune system mistakenly attacks the optic nerve and the spinal cord. The diagnosis of NMO typically involves a combination of clinical presentation, imaging, serological test, and CSF analysis. The patient was managed with ciprofloxacin for antibiotic therapy, prednisolone to reduce inflammation, and lubricants to protect the corneal surface. Refer to neurologist and for visual rehabilitation. I can't able to change my slide now.
There must be some internet instability in your side.
Yes, ma'am. I got it. Discussion. This case highlights the complex interplay between RP, neuromyelitis optica, DRS, uveitis, and recurrent corneal ulcers, emphasizing the importance of multidisciplinary approach. While RP primarily requires low vision aids and monitoring, NMO demands prompt immunosuppressive therapy to prevent further neurological damage. The corneal involvement in NMO coupled with retinal degeneration is rare and poses unique diagnostic and management challenges. Even when vision is irreversibly lost, management focuses on improving the patient's quality of life and preventing further complications. The coexistence of Duane syndrome, RP, uveitis, and corneal ulcers may indicate an underlying genetic syndrome such as Bardet-Biedl syndrome or Stickler syndrome, warranting genetic testing for accurate diagnosis. Conclusion. This case presents a rare combination of Duane syndrome, retinitis pigmentosa, recurrent corneal ulcer, optic atrophy, and neuromyelitis optica, causing severe vision loss. Despite irreversible blindness, managing comfort, preventing complications, and psychosocial support are essential. A multidisciplinary approach with early diagnosis, targeted treatment, and genetic evaluation can improve outcomes and quality of life. These are my references. Thank you.
Thank you, Latika. That is a very good case and a presentation. Ms. Daksha, you can ask her questions.
Yeah, nicely done, Latika. Just curious to know, how did you do the EOM, extraocular motility, for the patient? You said the patient was PL plus, right?
Yes, ma'am.
Gopi, are you saying something because you're?
There was a person here, yeah.
Okay, okay, sorry.
I wanted to ask the same question. Sorry to interrupt. How did they, even the diagnosis, I have a doubt whether it is advanced. Without even a normal person, 6x6, it's difficult to pick up the nuance in a go. In a PL negative patient, nuance identification is difficult. Yeah, ma'am, you can continue.
Yeah, so just if you can tell me how you did the extraocular motility. You said everything was whatever you said about Duane. So could you tell me how was it done?
Though the patient is a PL absent patient, to prevent further ocular damage, the patient was managed to prevent further ocular damage of inflammation, infection, and structural damage. The patient was done with
My
complete
question
comprehensive
is, my question is, how was EOM done, extraocular motility?
The previous findings of the patient demonstrated that the patient has Duane's.
But you have put it in the case that you saw on abduction and adduction. Like the case
Yes, ma'am, it was
presentation
from the
said
previous reports of the patient.
Okay, even you also have mentioned the EOM motility is full, free, painless. Everything is from the, so that should be written actually. It should be mentioned that from previous reports. It's not
Sure,
mentioned, so it looks like you have done it. Okay. Anyway, thank you.
And one more thing was, like, there was a mention of right eye development.
Sir, you are not audible.
I was only looking at the slides. There was a mention of right eye developed nystagmus. Actually, I'm wondering how only right eye had developed nystagmus. We have to look at the case, maybe into previous records, how patient presented initially. Okay, thank you.
Sorry, sir. Your question was how the nystagmus developed in the right eye. Am I right?
You can go to the case. Thank you.
Shall we move on to the person? Yeah. So the last presenter for today is Ms. Farzana Begum, U41.
Ma'am, can you hear me? Hello? Can you hear me, ma'am?
Yeah, Farzana.
Good afternoon, all. Myself, Farzana from SRM Medical College, B Optum 4th year. So I'm going to present a case on photic retinopathy, which is due to laser exposure. So what is photic retinopathy, which is also called as solar retinopathy? Solar retinopathy, also known as solar retinitis or photic retinopathy, is the condition resulting from excessive exposure to the intense light, which is such as direct sun gazing, solar eclipse viewing, or exposure to laser-induced flashes. So this condition causes damage to retinal cells, particularly the macula, leading to potential vision impairment. The overall prevalence of solar retinopathy in India was 0.01% of all eye diseases, which is diagnosed between 2010 and 2021, which is an 11-year period. And the disease is predominantly, which is mostly unilateral and more commonly affects the male. So in most cases, a recovery occurs spontaneously with no specific treatment within weeks to 6 months after exposure. But however, few cases have been reported in the literature using steroids in acute SR, which is solar retinopathy, because of their anti-inflammatory effects. So now we can see the signs and symptoms of this case. Signs includes yellowish, white, or red spot on the macula and macular edema. Symptoms like blurred vision, decreased visual acuity, and distorted vision can be present. So now we can move to the case history of this patient. 28-year-old male patient presented to the clinic with complaints of blurred central vision and the appearance of a yellow light spot in the central vision of left eye for the past 5 days. And he reported that a laser beam had fallen into his left eye. And he had no significant ocular history and was not using any medication and had no known drug allergies. And his systemic health was normal, and the patient did not wear any glasses. So now we can see the clinical findings of this patient: visual acuity with unaided right eye 6/6 and the left eye 4/60. And this is the objective refraction value of this patient. And subjective refraction, right eye plano with 6/6 vision, but in left eye there is no improvement with a vision of 4/60. In slit lamp examination, both eye was normal findings with no abnormalities detected, and IOP in right eye 15 mm Hg and in left eye 17 mm Hg. So now we can see the fundus examination of this patient. There was a retinal lesions present in the macula of left eye, and the optic disc media were clear for the both eyes. OCT was performed for this patient and confirming that retinal lesions in left eye was present. So this was the patient's OCT image, which shows the retinal lesions present in the left eye. And the final diagnosis was photic retinopathy. So now we can see the management and treatment. First, we can give systemic steroids. A course of systemic steroids was initiated to reduce the inflammation and potentially which improves the visual outcomes. And the next one, we have to educate the patient thoroughly about the condition, which includes its potential for recovery and the importance for avoiding the further light exposure and need for regular follow-up to monitor his progress. So in regular follow-up visits, he was scheduled to assess the patient, his visual acuity and fundus changes, and overall recovery. So in discussion, there's a significant difference. There's a main difference in visual acuity between the two eyes, which underscores the acute nature of the retinal damage, as the right eye maintained the normal vision and the left eye demonstrated the severe impairment. So SR is a self-limited entity, which is a self-limit, which can cure on its own with a complete visual recovery within weeks to months in most cases. But rarely, retinal injury may lead to permanent visual impairments and a significant restriction in patient's ability to perform his day-to-day activities. In cases of severe inflammation or persistent symptoms, we can give a systemic corticosteroid, which can help to reduce the inflammation, relieve symptoms, and can improve the vision. So we can go come to the conclusion of this case. Solar retinopathy can result from laser exposure, which leads to significant visual impairment, as demonstrated in this case. So timely diagnosis of this case, aided by clinical examination and OCT, facilitated the appropriate management. So systemic corticosteroids were used to reduce the inflammation and can potentially improve the visual outcomes. And then recovery from SR, solar retinopathy, is often spontaneous, but steroids can support better visual recovery in severe cases. And these cases underscores the importance of public education on the risk of laser devices and the need for protective eyewear to prevent the further ocular injuries. So these are my references, and I'm thanking to the patient and the family for the trust, and Dr. Kasinathan sir from the Kayati Eye Care for the guidance, and Dr. Aishwarya Radhakrishnan ma'am from Department of Optometry SRM, and OATN for the opportunity, for giving this opportunity. Thank you.
Thank you, Farzana.
Thank you, ma'am.
Daksha can lead your questions.
Yeah, Farzana, a nice presentation. Was this patient using the protective eyeglasses? Was that asked?
Thank you, ma'am. He was not using, ma'am, but as a role of optometrist, we can suggest him for the protective, personal protective equipment, which we can give laser safety goggles, welding shields, welding helmets, so green welding glasses, which was in shades, lower the shade number can lighter the lens, and higher the numbers can darker the lens.
Thank you.
Okay.
Just one clarification. Kind of was the patient?
So sorry, sir, I'm not hearing you, sir.
What's the patient's occupation?
Patient occupation. He's working as welding, sir. Welder, sir.
Okay. So, any years of experience do you have? Like, how many years you have been working in this field?
Sir, I'm not sure about that, sir. Sorry, sir.
Thank you.
Thank you, sir.
Thank you so much. So we have come to the end of today's session 3. I thank Ms. Daksha and Dr. Gopinath for their valuable time judging the 15 cases. I also thank the presenters for giving us some great learning experience, and it would have been good for the other participants also to learn new things about how to handle a case and new treatment methodologies and so on. So the general instructions, the next session will begin in another 10 minutes time. So whoever is presenting, who's there here, you can join in the next link which was shared to you by email. The results of this session will be announced tomorrow by email. So all instructions will come to you by email. Thank you so much for your time. Do we have to take a group photo? Can you all, yeah? Can you all open your video? It's great to see young faces, very energetic and eager to learn eager to present. All were very good cases. Others, Shakti, Madhunisha, a very senior person, BP Samal sir is also here. Okay. Kritika. Taking a screenshot. Thank you so much. Thank you so much for your time. So we can close this session. Thank you so much, judges.
Thank you, ma'am. See you. Bye.
Yeah.